Hello and welcome to clinicalpath.com. Today's topic is hypertension. Well, hypertension is really widespread in the Western world. The commonly quoted prevalence is that it affects somewhere between 1/3 and 1/2 of all adults. It is certainly the most common cause for doctor visits after pregnancy. It has an ethnic distribution and is more common in African Americans, and it increases with age. So for a group of doctors that are going to be looking after the baby boomers, it's going to be an everyday occurrence in the office. The definition is problematic, and let's talk about why it's a problem. If we just take a look about the fact that it increases with age, and we talk about what the risk is with increasing levels. If we start with a blood pressure here, and we talk about what's the risk from having that blood pressure, we start at about 115. No one can show that there's any bad effect getting the blood pressure below 115. And we can see then that the risk goes universally up. So that there's no single point where you can say, this is safe, this is not safe. So that when we say, what are we going to do? Well, we know that when we get up to 160, 180, now we're talking about very severe hypertension. But in that range, there's no natural cutoff spot. So when we talk about the definition, there's no safe level. And when you think about that, that's pretty comparable to glucose, as long as you don't get below 50, and hypoglycemia, and it's comparable for LDL. There are no safe levels of blood pressure, glucose, or LDL. And so we've seen that the definition has changed over time. If you go back to when I trained in the 1970s, the definition of hypertension was we treated only diastolics, and we only treated when the diastolic pressure was greater than 105. No kidding, that's true. And we were considerate when the diastolic was greater than 90. And you can see how dramatically it's changed. And the most recent change now has been in 2017. Just before we leave how we think about an organized blood pressure, when you're talking about, well, what should you try? Should you try to get everyone to 115? Remember that age is going to be a big driver. Most people are older when they get this. So you want to think of your target as actually being somewhere around 130 if the patient's over, say, 55 or 60, because you're going to need that to maintain kidney perfusion. So the very people who are most vulnerable, you have increasing vulnerability with age because everything is more fragile. The very people that you need to have the most strict control on, in fact, you're limited by the fact that they probably have some underlying nephrosclerosis, and so you've got to be careful not to take your old people below 130. Well, let's take a look at the new classification. The big change here is in the 120 to 130 category, because this used to be called prehypertension, and now it's called elevated, and that allows you to call it a disease so you can treat it. After that, we preserve this idea of stage 1, 130 to 140, and stage 2 is greater than 140. But note you can do systolic or diastolic, and that's been a big change over the decades. And you basically take whichever one is worse. So if diastolic breaks criteria, it's diastolic. If it's systolic, then that's where you do. I've just added in here to remind you that we have these other cutoffs for the hypertensive crisis, and the difference between urgency, in which there's no organ dysfunction, and emergency, where there is evidence of organ dysfunction, has really big implications for treatment. So this is a really important everyday working table, and one that you just have to carry around in your head. And the recent 2017 change is that we're starting to treat younger people at 120, kind of got to be careful with old people because of their nephrosclerosis. So what are the causes of pathophysiology? This is a good chance just to stop and get the right critical clinical phys into our heads. Remember that blood pressure equals cardiac output times total peripheral resistance. Then total peripheral resistance is the same as saying peripheral vascular resistance. And this occurs at the level of the arterial. So that's a fundamental parameter. And every time we're dealing with shock, that's important because we're going to divide our shock into those two groups. Cardiac output equals heart rate times stroke volume. And stroke volume is proportional to preload, which we sort of think of as venous function, contractility, which really is the amount of intracellular calcium, and then afterload. Afterload, usually we're just talking about blood pressure, which is the point of a discussion, so we wouldn't talk it. But remember, there are mechanical causes of this, such as a bicuspid aortic valve or coarctation, But generally speaking, it's blood pressure, so we aren't going to talk about afterload going on in the discussion. So let's take a look at how that works when we're organizing it in physiologic terms. Blood pressure equals cardiac output times total peripheral resistance. Cardiac output equals heart rate times stroke volume. Heart rate is going to be regulated by our sympathetic nervous system through the beta-1 receptors and the muscarinic receptors. It's going to be regulated by catecholamines. So autonomic nervous system, sympathetic, parasympathetic, and our catecholamines. Stroke volume is going to be preload and contractility. We've left off BP here. And our preload is going to break into the venous pool and the intravascular pool. Just to remind ourselves of that first time we were in cellular phys and we were talking about total body water, remember that that was going to break into intracellular and extracellular. And intracellular was 2/3 of your water volume. Extracellular is going to break into our interstitial and then our intravascular. And that's going to be 3/4. And then our intravascular is going to break into our venous pool and our arterial pool. And that's going to break into 80%, 20%. So when you're talking about your venous pool, you're talking about a small amount of the blood volume. But when they say intravascular volume, they're really saying effective arterial volume. So you can appreciate the very small changes in the arterial volume are going to have a big effect because it's actually a pool that's around about 800 mils. So when we talk about what are the things that are going to affect the venous pool, we're going to regulate that through our sympathetic nervous system, which is our beta-1 receptors. It's going to be our catecholamines, again, our beta-1 receptors. It's going to affect our arterial system mostly through our sodium and water. So when we talk about the intravascular volume or the effective arterial volume, this is about regulation of sodium and the water that passively follows it. So that's going to be sympathetic nervous system at the level of the juxtaglomerular apparatus. It's going to be aldosterone and antirenetic peptide at the level of the sodium channels of the collecting tubules. It's going to be ADH with the aquaporin channels at the level of the collecting tubule. And again, the same structure that does that is also going to give you thirst for drinking water. When we come up over now, we talk about contractility, which is mostly related to the intracellular calcium. That's going to be regulated by your sympathetic nervous system through the beta-1 receptors and your catecholamines, again, through the beta-1 receptor. Total peripheral resistance really has 3 levels of regulation. The first is it's under neural regulation by the sympathetic nervous system, now through the alpha-1 receptors. That's a GQ system. There are circulating regulators, which are mostly going to be either our catecholamines from the adrenal medulla or from our angiotensin II. Smooth muscles have a receptor for that. But then the local control is much more complex. Remember that there are metabolic signals to the smooth muscle, so that when we have indications of hypoxia, so a dropping O2 or a dropping pH, or we see inappropriate metabolic products like adenosine instead of ATP, that's going to cause vasodilation. We don't have any way to regulate that pharmacologically now. Remember, there's a very intimate relationship between the endothelial cell and the smooth muscle cell, and we have vasodilators like nitric oxide and prostaglandins, and then we have the vasoconstrictors like our endothelin and other substances. And then the last local control is by our angiotensin II at the level of the kidney. So that's just basic phys, and it really has a practical application because we use it for placing our drug manipulation. So this is one of the really good ways to remember the mechanism of action of our drugs, and let's just go through and see if we can do that. So our first drug for hypertension typically is going to be a thiazide, and thiazides, of course, are going to affect our sodium-water balance by the sodium chloride transporter at the level of the distal convoluted tubule. So that's a good place to think about our thiazides. When we talk about spironolactone is going to inhibit aldosterone. Beta blockers are going to affect it at the level of the heart rate here, and again, at the level of the contractility here, and as well at the level of the preload coming out of the venous pool. When we talk about our ACE inhibitors are going to affect our RAS system, so we're going to see that affecting the sodium potassium, but remember they also directly affect, because angiotensin 2 is contractile. And then our CCBs actually are a wide-ranging group that we typically think of as affecting the calcium level, so that's going to be at the level of the vascular system, so we think of it as venous pool and our arteries. So, basic physiology. How does that translate when we talk about the patterns of dysfunction we see in different systems? Well, there's no known etiology for most of the hypertension, so this is more of a general discussion. But the patterns of dysfunction we see is obviously we can see an increase in cardiac output. This is so-called pump-based hypertension, and this is what we see in young adults. So if you've got a 28-year-old's hypertension, you're going to be thinking more about cardiac causes. But by the time we get into the elderly starts getting that hyaline changes in their vessels, and old people tend to have an increase in total peripheral resistance. So that's the commonest thing you're going to see in your older population. Another cause is increasing blood volume, because that's going to increase both venous and arterial space. And when that's how we think of that, is that's going to be a renal-based hypertension. And just to show you that almost every type of hypertension does involve the kidney, if you transplant a normal kidney into a hypertensive, you get a drop in the blood pressure. So kidney is central to all discussions of hypertension. And then the last area we can talk about is neuroendocrine, because of this relationship of the sympathetic tone and the catecholamine levels. And so that can occur either at the central level, nucleus tractus solitarius, or at the peripheral level with the receptors and oversensitivity to sympathetic stimulation. Well, the challenge of hypertension is that it is asymptomatic for so many years. So if we were going to talk about how about it looks over time, in which we do our chronic disease model where we see a normal patient has risk factors, and then we see deterioration of function, but you don't have any symptoms. This is the asymptomatic period of functional reserve. And it's only when you get your first little stress that you unmask the patient as having disease underlying it. And then a small stress can take you to failure, and it's only when something actually breaks and we perpetually have a problem that we go into failure. So the problem with hypertension is you can go decades without it ever knowing. But when we talk about the pathology, we're back to this really important table of macrovascular. Macrovascular in the arterial tree includes large arteries and muscular arteries and small arteries and arterioles. The only thing it doesn't really include is microvascular, because this is really all diabetes mellitus. So when you say, what is the pathology of hypertension? When a patient says, I feel perfectly well, why are you going to treat me? The answer is, because let's take a look at all the disease. Let's start with our large artery of the aorta. In the ascending aorta, we're going to see cystic medial necrosis giving us an aneurysm. And obviously the symptoms are going to be when it dissects and ruptures. In the descending aorta, this is going to be atheroma, and that's going to give us aneurysm, which is going to give us dissection to rupture. In the kidney, the artery is going to be renal artery stenosis, and that will present as hypertension. The small vessels of the kidney are going to give us nephrosclerosis, and that's going to give us a gradual decline into stage 4 and stage 5 renal failure. In the heart, the artery is going to be coronary artery disease, and that's going to give us either our angina or our myocardial infarct. The microvascular disease really isn't described, but it's going to have the same presentation like kidney does, which is going to present with gradual loss of function because you're losing small bits of tissue, and that's going to be congestive heart failure. In the central nervous system, blockage of the artery, which is going to be our atherosclerosis, is going to give us our ischemic stroke. And the symptoms, therefore, will be those of stroke, which is classically your sudden loss of function. When we come to the small vessels, look at how different it is, because this is going to be our hemorrhagic stroke. So arterial patterns are different in the CNS. They don't occlude in the brain, they rupture and bleed. And so that's going to present as a stroke as well. When we talk about the peripheral nervous system, this is really a microvascular pathology. And then in the leg, the disease is going to be atherosclerosis, and we're classically going to see claudication in our femoral and our popliteal, but you can see it anywhere along that tree. And then when we talk about small vessel disease, this is just going to be really the changes of chronic ischemia, in which we get thinning of the skin and loss of hair and skin very vulnerable to ulceration. So, hard to overstate the importance of this table, right? When you talk about vascular disease, you break it into macrovascular and microvascular. Macrovascular breaks into the muscular artery versus the arterioles, and you've got to be able to walk down every system that you see here and describe where you find the occlusion, the pathology of that occlusion, and then what the underlying disease for the patient is. So this is one of the mandatory tables of medicine, and it organizes all of our circulatory disease well on the arterial side. So what are the risk factors for hypertension? By far and away, the number one risk factor is obesity. In America, this accounts for 2/3 of all the hypertension. And when we talk about obesity, this also includes the metabolic syndrome, which is that relationship of insulin resistance with hypertension, with increased triglycerides, decreased HDL, and then that abdominal fat. So metabolic syndrome is a really common association of that obesity. The numbers that they give is every 20 pounds that you increase will increase blood pressure up to 20 millimeters of mercury. So obesity, number one. Obviously, after that, we talk about things like age, genetics. Genetics, there really aren't any good monogenic. This tends to be a polygenic, although it does run in families. And remember as well, it's increased in African Americans. Exercise, taking your heart up to 80% max for half an hour 3 times a week has profound effects on health. So remember, the typical heart rate you're going to recommend is 200 minus age in years is typically the desired heart rate to get that benefit. When we talk about diets, we're talking about general things like sodium because of the salt relationship, and then calories for the obesity, but also alcohol is associated with high blood pressure. And then the last big group we can talk about are all the drugs that are related. And so the key drugs we want to talk about obviously are nicotine. Smokers that smoke a long time get a permanent nicotine hypertension. We want to talk about cocaine. And then last is estrogen of the birth control pill. Anytime a woman presents with hypertension on birth control pill, probably going to have to stop that medication and find her a different means of contraception. So when we talk about the clinical pathologic correlation of hypertension, we want to differentiate between primary hypertension, also called essential hypertension, which is idiopathic, versus secondary hypertension, for which there is a known cause. And it's really important because 90% of all our patients presenting with hypertension are essential, so you just don't go work them up at that point. Secondary hypertension, a known cause, really breaks into 3 major diseases. 90% of the secondary hypertension comes from 3 causes. One is chronic renal disease, and this is really going to be true in your diabetics, and again, paradoxically, in your hypertensive patients. It's going to be due to primary hyperaldosteronism, usually due from a hyperplasia of the adrenals, but an adenoma is possible. And then the third is going to be renal artery stenosis. So when you have a patient with possible secondary hypertension, in your mind you're going to break that into chronic renal failure, primary aldosteronism, and renal artery stenosis. Causes such as pheochromocytoma, COR, Cushing's, those are all much, much rarer. So when your patient presents with hypertension, you're going to bet that it is essential, and so that's not going to allow you to do a big workup. It's only when you have resistant hypertension that you get to work up for secondary. And resistant hypertension is defined as hypertension while on 3 medications. So ClinPath correlation, primary, secondary is a big divide. Well, presentation. Most of your patients should be asymptomatic and you've routinely done a blood pressure. After that, they're really presenting with complications of the vascular abnormalities. And these are going to be predominantly CNS, everything from headache, transient ischemic attack to to stroke, and then heart, because heart is going to go through angina, myocardial, and infarction. So most of your patients asymptomatic, CNS, heart are the common if they're going to present with symptoms. When you talk about the physical exam, well, of course, you could listen in renal artery stenosis. If they're not too heavy set, you could hear a bruit. But mostly you're going to go looking for the complications. So when we talk about the commonest arteries to get involved, remember you've got to look for your abdominal aortic aneurysm, you've got to look for your coronary artery disease, you're going to go looking in your carotids, you're going to go looking for your bruit of renal artery stenosis, and then your iliofemoral for peripheral artery disease. And these each have a physical exam that you should be able to perform. The one to remember on the physical exam, the only place that you can actually directly visualize the small arterioles and capillaries is in the retina. So a really good retinal exam is important. You're either going to see the notching from the thickening of the wall, or you're going to see the hemorrhages and cotton balls from the aneurysm, weakening of the wall and leaking. Well, what investigation are you going to do when we're talking about primary? Because remember, 90% are essential. Well, you're not going to do a lot, right? You're going to do your basic 3 that never have to be justified. So you can do your urine analysis, your CBC, and your basic chem profile. And when you talk about the ones that are of particular interest, of course, you're going to take a look at creatinine, which you're going to convert to an eGFR, because that will pick out our chronic renal failure. Pay particular attention to potassium, because 70% of your hyperaldosterone patients are going to show that. And then obviously glucose is important because diabetes mellitus is such an important risk factor for atherosclerosis. Some of the other things you're going to do in particular, just to think about it, obviously left ventricular hypertrophy is a problem, so an EKG is a good thing to do. Risk of atherosclerosis is important, so a lipid profile is helpful. And then just to be complete, you're going to get a TSH because hyperthyroidism can be associated with hypertension. The patient that can be defined as resistant hypertension, and remember this is defined as hypertension while on 3 medications, this really becomes the investigation of the big 3, chronic renal failure, primary hyperaldosteronism, and renal artery stenosis. Well, your eGFR will rule out your chronic renal failure, so this is really the differential diagnosis of primary hyperaldosteronism versus renal artery stenosis. And to do that, then we do an aldosterone-renin ratio. And that's sort of one of the really important little test sequences to think about. So let's just take a look at what that would look like. Here's our renal artery stenosis, and here's our increase in our aldosterone. And what you're going to do is you're going to get a serum aldosterone level and a serum renin level. And this just becomes a little evaluation of the feedback loop. So in renal artery stenosis, that's going to cause an increase in renin, and through the RAS system, an increase in aldosterone. So we're going to see a ratio which is low, and that's described as less than 25. But in primary hyperaldosteronism, we're going to have an increase in aldosterone and a decrease in renin, and so we're going to have a high ratio. And after that, then, once you've decided you've got one or the other, then you can go for imaging to look for the specific abnormality. So how do we treat our hypertensions? Well, always and ever lifestyle, right? Remember all the things we talked about in risk factors. 2/3 of it is related to obesity. Just exercise alone is fundamentally important in regulating blood pressure. Diet, obviously calories matter for obesity, but particular attention to salt. Some people are quite salt sensitive. And then alcohol and cigarettes obviously can contribute specifically. And then for females looking for estrogen and the birth control pill, that matters as well. So always start with lifestyle modifications. It's important in theory, actually quite hard to do in practice. And then after that, we start treating. And these are our basic drugs. And this is such a common disease, we have to be able to just knock them off. So you should be able to look at these. Remember, everything in medications is mechanism of action, interactions, and complications. So mechanism of thiazides, that's going to be our sodium chloride transporter in the distal convoluted tubule. Spironolactone is going to decrease the sodium channels in the collecting tubule. Remember, it doesn't have a receptor because it's fat soluble, it goes straight to the DNA. Beta blockers are going to have multiple effects at the level of the SA node. We've got our beta 1 receptor, and that's going to decrease heart rate. At the level of the cardiac myocyte, again, this is a B1, it's going to decrease the intracellular calcium and decrease contractility. When we talk about ACE inhibitors, remember the ACE inhibitor is the angiotensin 1 to 2 conversion, and so that's going to decrease angiotensin 2, which is going to result down the RAS system in a decrease in aldosterone. Problem with ACE inhibitors is 20% of the people have a cough, and then there is rare angioedema. So in those people, one can substitute the angiotensin 2 receptor blocker, which will have great effects not only at the level of the RAS system, but is also going to affect the smooth muscle of the vascular tree. And then CCBs decrease intracellular calcium by blocking the voltage-gated calcium channel. Well, we'll just finish up in the farm here. Notice that there are some special situations. When we talk about patients with congestive heart failure, thiazides are a really effective drug to start with because they decrease blood volume. If someone is post-MI, certain medications have been shown to improve lifespan, so this includes our beta blockers have been shown to increase longevity, the ACE inhibitors have been shown to increase longevity, and aldosterone has been shown. So those are all good choices post-MI. In the elderly, we've discussed that this is an increase in peripheral vascular resistance situation commonly, so using a CCB as a vasodilator is a good choice. And then in diabetics, because they have the kidney disease, or anyone with just direct kidney disease, using an ACE inhibitor is useful because that decreases our intraglomerular pressure and prevents the focal segmental glomerulosclerosis. Hypertensive crisis refers to severe hypertension and is usually defined as a systolic greater than 180, you'll see some sources talk about 200, and a diastolic greater than 120, but the truth of the matter is there's no absolute level because the more rapid the rate of rise, the more difficult it is for the body to handle the pressure. So when we talk about severe hypertension greater than 180 over 120, we want to differentiate emergency from urgency. So emergency is going to be this blood pressure plus organ dysfunction. So the definition then is a clinical definition in which you not only have to have the blood pressure, but you've also got to show the organs, and classically the organs we're going to be talking about are going to be our CNS, our kidney, and our heart, but obviously all through the body we can see problems. If you go back into older literature, you'll often see it referred to as malignant hypertension. And this comes from back about 1928 when they first recognized this entity. And they had no treatments for it, so all they could see was the natural history. And so the natural history that they observed was that these people had about a 20% one-year survival. And that was the same as the aggressive cancers for which they had very limited treatments as well. So they thought that this hypertension had the behavior and natural history of an aggressive malignancy, and so on that basis they called it malignant hypertension. It's really been superseded now by hypertensive crisis or specifying hypertensive emergency or urgency. The pathology we see in two different patterns. This is the pathology of small arteries and arterioles. The first and commonest pattern that we see is fibrinoid necrosis. And this is a misnomer. First of all, the proteins that we're seeing is actually fibrin driven through the damaged endothelial cell into the wall. So it's not fibrinoid, it's actually fibrin. And it's not really necrosis. You're just seeing the presence of the protein in the wall. So it's a sign of endothelial damage and barotrauma that allows that protein to be there. The second pattern, probably because there's a more chronic time frame, is when we see hyperplastic arteriolosclerosis. And what we see with that is instead of seeing a vessel with the fibrin driven into the wall looking a lot like pink bubblegum, instead what we see is the vessel and a proliferation of connective tissue and smooth muscle cells around it, probably to try to form a protective wall. And so hyperplastic arterial sclerosis is different because it has cellular proliferation. But both are patterns of severe hypertension. The pathophysiology is really one of overwhelming the mechanical pressure and especially those organs that have autoregulation. And our two key organs with autoregulation are going to be in our CNS and our kidney, and they become the first two organs we always think about and talk about in this. In the CNS, what we see is we start to see the rise of increased intracranial pressure. And the leaking of the fluid past the vessels gives us edema. And that edema then causes more and more pressure with rising intracranial pressure, and that manifests in your patient as headache, which can progress on to encephalopathy, which can present on into coma and ultimately death. And when you see these patients on examination of the retina, they're going to have papilledema. In the kidney, we overwhelm the autoregulatory system, and what it means is that the systolic blood pressure is now going to be the same as the intraglomerular pressure. And the intraglomerular pressure simply can't be sustained, and so we see rupture and hemorrhage. And if you take a look at the surface of the kidney, you see all these little hemorrhages in the glomeruli, and it gives all this little blood spots on the surface of the kidney, and that's called a flea-bitten kidney because it looks like the blood of fleas on skin. And then the last organ that we see problems in is going to be the heart. And in the heart just goes into acute failure, and that's just due to the overwhelmingly high afterload. So when we talk about what these patients are going to present with, obviously they're going to present with shortness of breath from pulmonary edema. So there's lots of other organs that could be involved, but identifying CNS, kidney, and heart changes are always where you're going to start in this disease. Well, how are we going to treat it? Well, obviously we want to decrease the blood pressure, and if there's evidence of organ dysfunction, we want this to be really rapidly dropped. So the treatment is going to be to decrease the blood pressure to less than 180/120 in the first hour. So that's about 25% drop in blood pressure. And then we want to decrease it to less than 160/120 over the first day. So we can see that this is not instant drop, but it's a very rapid drop. And so to do that, you're going to use intravenous, short-acting medications. And it's going to be a continuous infusion. That's why you've got to have short-acting drugs so you can literally follow that blood pressure and bring it down. Lots of different drugs do this, nitroprusside, other drugs. It changes a lot and there's no single answer. So that's something you can look up specifically in pharm. A couple of special situations. If the patient presents with hypertension and aortic dissection, 1 hour is not fast enough. You really want to decrease that within 10 minutes, and you're just going to use beta blockers for that. And then the other exception is ischemic stroke, where you really don't want to decrease the blood pressure, so you're going to be very cautious, and only if it's extremely high, like say it's greater than 220, you could talk about decreasing it then. Otherwise, you're going to get them through their stroke period before you give them more hypoperfusion. Now, hypertensive emergency, that's a different entity. And you'll sometimes see it referred to as severe asymptomatic hypertension. And the definition is, of course, it still has a high blood pressure, so your blood pressure is still more than 180/120 diastolic, but there's no organ damage. And that changes how we want to treat it. Because now the treatment is not one of rapid, we want to have a short-term change to bring it below 160/100, but we want that to be over days. And then long-term, by which we mean weeks, you want to bring it back to the more acceptable 140/90. So you can see there's this totally different time profile, and you're afraid of dropping it too quickly if there's no organ dysfunction, because organs compensate and a rapid drop will leave them underperfused. Now, the commonest cause is someone who has stopped taking their meds. So if that's the case, then basically all you're going to have to do is resume the meds they've stopped doing. Okay? So, hypertension, Just to summarize here, the big idea in hypertension is primary is essential idiopathic, and you don't do much more than a minimal workup. Secondary has a known cause. Remember, this is going to be chronic renal failure. It's going to be primary hyperaldosteronism, and it's going to be renal artery stenosis. So knowing how to do the aldosterone-renin ratio is a big idea here. Second big idea we talked about is the difference between a hypertensive emergency with organ dysfunction and a blood pressure that has to be dropped down over hours versus hypertensive urgency in which there's no evidence of dysfunction and the patient should resume their meds. So hypertension is mostly a disease of pharmacology and well worth spending your time mastering that. That's the end of this tape. Thanks for listening.